going to come soon.
Yes, and I'm showing my willingness by doing this at 3 or 4 in the morning, but I'm up anyway, so I'm very dedicated. Dr. Fozzi, it was great to meet you. Thank you.
My pleasure.
So much for coming. You were nice enough to come and visit us, and I didn't have enough hospitality.
Now you have an excellent work. I visited the unit, the center. Great work is being done. Now you have the mic. Thank you very much.
Okay, thank you. Yeah, I'll try to keep this on time, under 20 minutes. So I just want to talk about point-of-care AI deployment and the lessons that we've learned. And we use AI plus HI, which is AI plus human intervention. And some of the strategies we've learned and lessons and how to pick it for, or how to strategize the deployment for particular systems. So from the University of Miami, as Dr. Fozzi was nice enough to tell me. And if there's any technical difficulties, by the way, I do have we have an uploaded version that you can play the audio, but I've shortened this a little bit. So just for example, this is what our current system of deployment looks like. Head CT on the left, CT pulmonary angiogram on the right, and obviously the heat map shows where the abnormalities are on those images. I'll talk more about that in a minute, but I want to give a brief background about AI and how I think it'll affect jobs, particularly radiologist jobs, and those, not just radiologists, the technologists, administrators, care coordinators, et cetera, because that'll be part of the HI or the human intervention I'll talk about in a minute. Some think it will augment positions but not eliminate them. Others think that AI will substitute positions and thus it will eliminate them. I have the opinion that it will create new positions, new skill sets, and new industries, is my opinion. And just as a background in the United States, radiology is by far the highest source of revenue in the hospital systems, brings much more than other, it doesn't mean it goes to the radiologist's pockets, up to 40% of hospital revenue or more, particularly in small hospitals, but the reimbursement's decreasing at a rate of 2 to 3% a year. So this is really leading to this drive towards increasing productivity and lacking outcomes, which we call commoditization, right? And the commoditization curve is, I'm sorry. Can you guys hear me?
Yes, go ahead. Thank you.
Okay. Yeah, I can stop my video if it's a problem. So this driving this commoditization curve, and what's happening is the imaging market size is going to double over the next 10 years. So the threat of commoditization to radiologists will increase with having a 14% compounded annual growth rate. And again, I don't know about the whole entire scene across the world, but in the United States, this is really leading to increasing commoditization, which is decreasing reimbursement or price of the scans, for example, with also a decreasing supply of radiologists. I mean, sorry, not decreasing, but not increasing supply of radiologists commensurate with that increase. So this is driving burnout, and as I said earlier, we're in the 50 to 60% range of burnout of radiologists. 50% of the radiologists have actually changed their practices in the United States in the past 5 years. And there's a 50% decrease in reimbursement over the past decade. So really, we have to find ways to change our workflow, but also continue to demonstrate our quality and provide impact on patients. And so there's 3 ways to do that, right? I mean, one, you can use, 3 ways to use AI to improve workflows or continue these workflows and continue to make money, frankly, because we are a fee-for-service system. Right, is that one is we can use AI and various other technical breakthroughs to increase the productivity, right? Display them faster, get them read faster, get preliminary reports faster. We can use them to increase other workflow efficiencies, like in dictation, linking EHR, relevant data, getting data from the EHR, making calls, communications, follow-ups, etc., streamlining those parts of the radiologist spend times on the phone, for example. Or we can spend our AI kind of capital on, which is really not a focus as much today, but showing value and quality and documenting impact, having better billing and coding and complexity. That third area I think is a real opportunity, but it's not something I'm going to talk about today. So I'm going to focus mainly on workflow efficiencies and making sure that a patient gets back within your system. Both, it's mainly doing the right thing for the patient, right? And I think it's going to show that radiologists have an effect on outcomes over time. But so I'm not going to focus as much today on billing and coding and those types of things. So just kind of here's what a next generation radiology PACS system may look like, where the most likely to be positive things come up to the top. It lists kind of where they are in the ED, observation, stroke, et cetera. And then what I call the positive prioritization time is it'll prioritize those things that that we read as a radiologist, and the finalization of those to the top based on the preliminary AI findings, as you can see here in this intracranial hemorrhage, and it'll point those out for us, and then we can actuate that and turn that into bring a patient back quicker. But we decided to go a little bit different direction with it, even though we do have it do that positive prioritization. And I'm going to talk about our direction in a second. I just want to quickly talk about where we are with the number of devices cleared in the United States. Over 800, 75% on radiology. Unfortunately, they really don't have medical approval bench to bedside. It takes 10 to 12 years because in the United States we don't want to shun development and advanced technological advancement. So what happens is they use predicates, and there's only a couple predicates used for these. In other words, they're following a similar pathway to get clearance back to 2001, and so they can get the clearance pretty quickly. Most of those are actually in radiology. The number one kind of build for AI is actually in radiology. Number two is actually in ophthalmology on diabetic retinopathy. So this is leading to just greater number every year of clearances, and so now we have over 800 clearances I last checked. The most on the risk severity, the most kind of highest risk is potentially the CAD-E, or the detection and diagnosis of disease, computer-aided detection and diagnosis of disease. And on the lowest level is the acquisition data optimization, which I was going to talk about, but I won't do that today because it's really not related to the point-of-care AI deployment as much. And so what's happened is about 13% of them are in that higher risk range, and they cost more to develop and evaluate and do kind of ground truth testing. And the triaging and the acquisition are less risk, and those are kind of the majority of what's happening. So there really is an adoption rate potential to be increased in the United States by the radiologists. And there's also not as many CPT codes, what we call procedural codes for reimbursement. And I think there's going to be greater adoption as we get more codes of reimbursement, which are technical reimbursement, but also as we kind of figure out these workflows, to get back to my last couple slides. So one of the big issues, as I see it show in the bottom right in pink or purple, is that all of AI needs human oversight, particularly in the United States. The radiologist, another talk for another day, is considered to be the arbiter and actually the one that's legally liable, whereas in the EU, they recently just passed a rule that it's a vendor. So in the United States, people are worried about adopting it, partly because, one, they're worried about their workflows being interrupted, but two, they're worried about, being responsible for what the AI, if they're not. So it's really important to stress here that in the United States, we have to do a pilot ourselves, in my opinion, to see how that works. And that'll fit into our scheme in a minute. So where does our point-of-care AI deployment? I just want to show these overall circles. Like in the realm of data science, I love Venn diagrams for those that know me. And the natural language processing, natural language generation, natural language understanding fit in there. But imaging triage is kind of in this overlap of data science and imaging AI. And this is a big part of what I'm talking about today. And past imaging triage, I'm going to talk about management of the patient workflow after that. So human intervention, HI is not on this slide, but it's critical, and that'll be kind of coming towards the end of the talk. So what are the goals of deploying an AI strategy for imaging, particularly in the United States, is that we have to create a workflow to minimize interruption to radiologist performance. We have to have a target start date and waypoints. I'm from Minnesota, Roseville, northern United States, and that's where Target started. So I'll talk about targets a lot and dates and waypoints, just because that's where it got started. For those of you that are familiar with that brand. So just some strategic deployment considerations before we deploy AI. We think about, what is the goal? What is the use case for the hospital system? What does our market research show? What are regulatory, ethical factors, pilot testing, integration into workflow and IT, training, technologists, and then monitoring and QA, iterative improvement. And with the vendors, there is a huge increase in cost for what we deploy over time, because the vendors will try to charge you per algorithm $80,000 to $200,000 a year per algorithm. You can't afford that if you're going to do 50s or hundreds of disorders. It'll just be prohibitively expensive, millions of dollars a year. For the third-party software, sometimes you pay extra money. So the vendor relationship really requires, I believe, trust, open, iterative, frank engagement. There needs to be performance evaluation and stewardship on the part of the radiology group. And there's really three approaches to AI implementation, which I'm not going to get much into today because this is almost its own talk. But really, there's the kind of narrow point solution, like I have one solution, one for hemorrhage, another vendor for PE, et cetera, et cetera. There's a third-party marketplace, which is increasingly common. I kind of believe in having a platform, an operating system where you have, one or two or three vendors with value partnerships, and you really do everything they can, and you work together, and they have good support. So clinical AI is difficult to deliver, and I call this the AI sandwich, because we expect that an algorithm just drops on top of the platform, but really it's not the same as a solution. In reality, it's more complex. Human intervention is involved. I look at AI strategy kind of like the meat in the middle of the sandwich. The platform is the bottom bun. There's the sauce of the algorithm. Human intervention is kind of like the tomato, and the lettuce or the vegetables, validation and performance monitoring. And the top bun is like IT integration and acceptance. Sorry, you could tell I'm hungry at 3 in the morning, and I just kind of call it the AI sandwich. And that's more complex. It involves HI. So what happens, right, is that we really started initially with just intracranial hemorrhage of pulmonary embolism for the emergency department. And that's mainly what I'll talk about today is the pulmonary embolism and incidental pulmonary embolism in the outpatients that happened after that emergency department evaluation and pilot. Then we're moving into vessel occlusion, brain aneurysms, pneumothorax, malposition tubes, et cetera, and more things next year, particularly coronary artery calcification. I'll talk about at the end. So it's really important to curate them. I can't stress that enough. And so we just don't deploy them right away. We actually have pilots. And so we started with an ED pilot. And in our ED, emergency department pilot, we decreased the finalization times in the positive cases for intracranial hemorrhage by 28%, and for the pulmonary embolisms by 46%. This was really the emergency department. We're not talking about outpatient yet. That'll be the next subject, right? But the nice thing is there's these, for the care coordination teams, they have these these provider-facing apps and patient management tools, which enabled us to actually look, for them to look at our findings and see what the AI was showing, and actually for PE detect things like right ventricular heart strain, to accelerate towards thrombolytic therapy, et cetera. We thought about, hey, is there a use case beyond this? And I coincidentally had the hospital executive call me about all these people who had, we didn't have enough radiologists at the time. There was some issues with the report turnaround times being a few days. Now what happens is some people actually show up in the emergency room as outpatients with PE, noted for like on an abdominal CT or a chest CT that wasn't done for pulmonary embolism, right? So I said, wait a minute, we have a 40% to 50% cancer population. Let's start evaluating incidental pulmonary embolism. So, okay, so what did we do? When our population is 50% oncologic, what is the actual incidence? Well, it's 1 to 4% will have incidental PE. And then they have a much greater risk of incidental PE than the greater population, 10x or more. And then many of those are not actually reported. Unfortunately, they can be missed, according to research. So we wanted to find a way to identify, stratify risk, and triage the patients. And the hint is this requires some human intervention, right? So just quickly, here's a typical kind of ED pilot. The heat map shows there's a segmental pulmonary embolism there, and I'm not a chest radiologist, so you can correct me, but on the right side there's a filling defect. And here's an incidental PE, similar algorithm. There's a heat map showing what segment the clot will be in, and there's a much smaller clot there, right? This was in a patient having a pancreas cancer. So it was actually for an abdominal CT, and the chest was at the bottom of the study. So, what constitutes an incidental PE study, just it's basically something that was not for CTA for PE. It is usually like an abdominal CT or a chest CT for, lung cancer or whatever it might be, cough. They're not done with the dedicated CTA protocol for PE. And then what happens is the radiologist will, this person has big pleural effusions, but they'll get this heat map that shows up. And I'm just showing you what it looks like on the radiologist work screen, and the heat map will show that there's something in the area, and then they'll, point out where the PE is. So our incidental PE data, when we started running the pilot over several months, is that we found out that actually 1% of our CTs are positive, which made sense because 40% of our patients have cancer. So it's about half of the national registry's average, right? And sorry about this, thing's automated a little bit. And so we also found that it decreased the read times in those positive cases by 3 hours. compared to the negative cases or compared to the overall list. So we call this, positive prioritization impact or positive prioritization time impact. And basically, with that 1% being positive that I just mentioned, we also had continued this, as I'll get into the point of care AI deployment here in a second. We continued to monitor these numbers over time. We found that, that jumped again. 1,700 out of 46,000 patients were positive. Now that included the ED and the outpatients together, that number, but just shows you how many of these patients in an oncologic registry can be positive. And now we're moving on to other algorithms. But I think this is the biggest slide to show how much impact AI has had on our workflows. With outpatient aneurysms, we've had 91% faster read times because we moved those to the top of the list. It kind of points out the finding. Incidental outpatient pulmonary embolism, I think the speaker, Amanda, earlier, if I got her name correctly, talked about opportunistic medicine, and I call it preventional radiology, but it's a great term either way. And then basically our wait times have decreased from acquisition to dictation in these positive cases, and the positive findings receive care faster. And what I'm going to talk about here is how these cases are followed up. And our point of care AI deployment starts at the scanner, actually. We consulted heavily with legal and medical legal. The patient will not leave the scanner. It will run all these various AI algorithms. They leave the scanner, they don't leave the facility. So they'll, sit in the room next door while they wait for the result. If it's positive for any of these things if it's negative, they go home. If it's positive for any of these things, there'll be a disposition. The radiologist reads it right away. And the advanced provider or the radiologist will quickly communicate the findings of the patient, and they could occasionally go to the emergency room, but more commonly there'll be a follow-up appointment right away. And we call this whole thing human intervention. Sounds simple, right? Well, it's actually this very complex interplay here of how this actually happens, and we have a whole workflow. So here's our lessons learned in our ambulatory care facilities. We have a number of clinical coordinators, advanced practice providers, nurses, et cetera. And what we found is that about 30 of these incidental Ps are urgent, and the imaging streamlines care. The personnel are really broadening their skill sets, and they're having a lot of job satisfaction. They're being trained by the vendors. This led to job development opportunities. But the biggest part of this, besides curation I talked about, is also the interprofessional communication has improved. Being open to feedback, being open to changing the workflow to triage by severity. Sorry, that slide jumped again. And one of the biggest things we've been focused on now is the direct and secure messaging apps, not just between the providers, but even now we're getting to how to deal with the patients, how to make them informed, and having patient-friendly, reports and workflows. So this is all really started to be centered around the provider and how to triage this. Now it's getting centered on the patient. So our next biggest thing is incidental coronary calcifications and figuring out what to do. The surveys have shown that most patients would like to have a cardiology follow-up if they have those. I believe the radiologist can become a preventionalist, and what this looks like is the coronary calcium, as you can see, will be pointed out by the AI. It'll give them a severity score here in the bottom right, and then they set them for follow-up. And I just want to stop on this slide here because we've went through our legal team, had it set on the kiosk that the actual, there's a avatar that gets their consent to use AI to make sure they're followed up. The United States, we always have the payment, and they're not really paying for AI at this point, by the way. This is just kind of part of all the permissions that we get. But getting permission, particularly to use AI, not only for the evaluation, but for the follow-up of the patient. And I think the next biggest thing that we're going to focus on, because we just started the coronary calcification, is the breast arterial calcifications. The prevalence is about 12% plus in screening mammograms, increases with age. They have a significantly increased risk of a coronary event or heart attack within the next 10 years. If they have that, sorry, it just jumped again. And this just shows you what the algorithms look like. They'll pick out the arterial calcifications, and we want to use that to trigger an appointment for follow-up with a cardiologist, just like the incidental coronary calcification. So some concepts for discussion is really, how do we want clinicians to see our AI as radiologists? Some say maybe cardiologists and pulmonologists should also have their way to get these results and even theoretically do interpretations. I'm kind of not so much for the latter, obviously. Who's going to be the diagnosing patient in the future, provider in the future? But I believe it's very important to understand that HI is critical to empower AI. We were just one of the first Arch AI programs, which is the ethical and moral use of AI, and there's a whole governance system that's set up to be one of these for the American College of Radiology in the United States. I have a IT team that helps do that, and we score. Oh, sorry, I wanted to stop here. This thing is jumping on me. The really needs to be an institutional palette for change if you're going to center this workflow around patients and making sure they follow up. And there needs to be an AI strategy and a system leader. There needs to be a budget for AI with a critical eye towards the spending. And I talked about some of those considerations earlier. And it might get into like whether you're service-based or service line-based, et cetera, a lot of other discussions. But there is, and B here, an importance to really have a frank discussion, HR type discussion about the advanced care providers, coordinators, and look at what type of jobs are going to be created or moved over from previously. So I don't think the radiology chair should be a barrier. I think they should actually facilitate the AI discussion. And one of the earlier panelists described this. The biggest growth, there's an opportunity for musculoskeletal, as she mentioned earlier, and also cardiology is probably going to be the biggest one over the next 5 years, some say. There has been extensive growth already in neurology and pulmonology. I believe the next phase is task-based agents that are going to help eliminate some or improve that workflow burnout that we're having now and productivity burnout. And I think they're really going to take care of some of these issues we have with workflow, but also help demonstrate our quality. And this is my last slide. So I think radiologists can feel entrapped or they can get enlightened by AI, particularly with these next generation PAC systems that the AI is going to be built in, the communication with the provider, or even maybe the patient is going to be built in. I think the reports translated for the patient will be built in. Could point out the findings of them. There's a lot of fighting between cloud infrastructure, between various vendors now, because it's almost like energy usage, like gas or teraflops or something. And it's going to be really important to pick your cloud vendor for all of your post-processing needs and have that be fiscally responsible about it. And then the AI vendors themselves and their various accuracies are important. So radiologists can be kind of trapped in this prism, or this can be a kind of a source of freedom, liberation, and enlightenment and improve our quality of workflow. So I think either we can be commoditized and trapped by it, or we can get enlightened and it improves our experience. So I just want to thank everybody, even if you're in AI. Thank you for listening to this talk.
Thank you, Professor McKinney. Sorry, go ahead, please.